All right. Thank you for giving me this opportunity to present on this topic, Parkinson's disease. I'd like to thank Dr. Stein and Dr. Burnham for this rotation that I had. It was a wonderful learning experience, and we saw plenty of patients, out of which Parkinson's disease is one of the diseases that does, entice me towards the movement disorders uh, part of the neurology aspect. So I would like to present on this topic today. So Parkinson's disease is one of the most common Parkinsonian symptoms and syndromes. It is manifested basically by rest tremors, rigidity, bradykinesia, and postural instability. It's a four trap. It's known as trap, considering four different things into its syndrome. So the worldwide prevalence is 0.3% in 40 years of age and above, and there has been noticed a male predominance in most of the epidemiological studies, but it hasn't been confirmed with anything, but it's just observation, like most of the epidemiological studies showed a male predominance. So in terms of the pathogenesis of the Parkinson's disease per se, most considered pathways like the dopamine depletion, which happens more so in the substantia nigra and in the nigrostriatal pathway to the caudate and putamen, which ultimately results in inhibition of the thalamus and reduced excitatory input to the motor cortex, which itself presents as bradykinesia and other signs that we see as resting tremors and postural instability. So the risk factors include family history, which is one of the most important risk factors. There has been a male predominance, and even though in the family history per se, it's considered more so in the male lineage than the female side. So exposure to pesticides is one of the most important things. I was following one of the movement disorders fellows and attendings per se, and she was telling me that we do ask one of the important questions when the patient comes in with Parkinson's is whether they live in rural areas or the urban areas, because that makes a lot of difference in terms of pesticides exposure, and exposure to rural areas has been found in studies to be directing towards more of like risk factors for Parkinson's than living in urban areas per se. And apart from that, high consumption of dairy products have been considered one of the risk factors. And patients with history of TBI, the traumatic brain injury, have had the onset of Parkinson's disease earlier than normally 40 years and above. So apart from that, if there is a reduced like vitamin D levels in your body, like either dietary or sun derived, so that can also lead to Parkinson's per se in future. History of migraine with aura is also considered one of the risk factors, along with uh, metabolic syndromes and type 2 diabetes mellitus and morbid obesity. So it's something interesting here, protective factors. Uh, most of the observational studies have shown an inverse correlation between Parkinson's disease and smoking. I was looking up on UpToDate and different journals I read about this, and they said that it's in a meta-analysis of about 26 observational studies, there was a twofold lower risk in current smokers. And that has, according to the different theories that came up for that, they said that either the Parkinson's disease patients, they take less of, like they smoke less, or it's one of the basic criteria that they smoke less either, or it's because of either the dopamine pathway, which is a reward pathway, which happens after smoking. So if they smoke more, they have more of dopamine in their body, especially in their brain. So that leads to less of symptomatology of Parkinsonism, because that per se is also due to dopamine depletion. So if the patient smokes, they end up having more dopamine and have less likely possibility of presenting with Parkinson's later on. So this is something interesting. Also, caffeine intake and the coffee intake has been shown to decrease the uh, incidence of Parkinson's disease, which is something very important. One of my colleagues also is caffeine addict here. So like we were wondering, how does it help? So this is where you can have a little bit of help. Aerobic exercise does help you almost in any other diseases. Also, the medications like ibuprofen, statins, and alpha antagonists like terazosin and doxazosin, which are used in hypertension as well as in BPH, they have been shown to be protective for Parkinson's disease. So one of the main clinical manifestations, firstly, as I told you, there are four basic clinical manifestations. The first one is the most prominent one is the resting tremor, which is normally basically called as pill rolling tremor. It's a characteristic tremor. Frequency of it is almost 4 to 5 often, and it gets supported by the gravity and not engaged in purposeful activities. It's shown more so when you are resting and not making your limb move. Presenting symptoms, it is one of the most common presenting symptom in 70 to 80% of the patients, and it usually starts with one of the hands and then spreads to the other hand several years after. So here is a video demonstrating the pill rolling tremor.
Very good.
As you can see, the characteristic pill rolling, especially when the hand is lying on the lap and not moving. So this is the characteristic pill rolling tremor, which can be differentiated from other action tremors like cerebellar involvement and essential tremors per se. But this can happen even from, I'm trying to close this video. So this can happen even from the atypical the other causes of Parkinsonism, like drug-induced Parkinsonism caused by antipsychotics as well. So the other common presenting symptom and sign is bradykinesia. So it almost always present in the Parkinson's disease patients as well, about 80%. So the patients come in and say that they have weakness, incoordination, or tiredness. That's how they describe it as in the decreased ability to initiate a voluntary movement. So they have, it's one of the important questions to ask each of the Parkinson's patients is like, do you have difficulty buttoning buttons? This is what I've seen after following one of the attendings. She was also telling me that like shoelaces tying and buttoning, as I told you, is one of the in movements that involve your dexterity. So that is a bit lost in here because of bradykinesia. They also have difficulty lifting coins from the pocket or from the purse. So apart from that, they also have shorter and shuffling steps, and they have slow movements on the arms as well when they walk. So they also have difficulty standing from a chair or getting out of the car when they sit. So that's why these days push button chairs have arrived in which you just push on the button and then they help you sit up from the sitting on position. As the disease continues to progress, there is a development of gait freezing or what you call fascination. So fascination is a phenomena in which the patient follows the center of gravity since they have a stoop posture towards the front. So their center of gravity really rise ahead. So they develop that short steps gait in which they continue to follow their center of gravity to maintain it under the person and not in front of him so that it doesn't fall. And the third common presenting symptom is rigidity or sign. So they have increased resistance to passive movement as well, as in what we normally do not assess. We always go with active movements, but they have resistance to passive movement, which the patient describes most often as well, which occurs in 75 to 90% patients. So it also begins more so in one arm first or unilaterally. I'm hearing an echo. All right. So as I mentioned, so it starts in one of the limbs first and then progresses to the other one. Commonly, it's known as cogwheel rigidity. That is how normally they present, and it can also lead to lead pipe rigidity later on. But like, just not every patient have cogwheel rigidity. Some may have lead pipe rigidity as well. Cogwheel is defined as a ratchety pattern of resistance in which you keep on, stretch, asking for the strength and like move the one of the limbs, and they have ratchet pattern, ratchety pattern of resistance. And and examiner as it and like gets to know the relaxation pattern as well as the rigidity which is on and off. The fourth thing is postural instability here. So there is an impairment of centrally mediated postural reflexes, which is postulated to be one of the causes here, which leads to imbalance and tendency to fall. So it usually appears very late in the presentation. And when it is present just at the time of initial presentation, it could be the signs of another Parkinsonian symptom or sign, which could be due to atypical Parkinsonianism, like progressive supranuclear palsy or multiple system atrophy. It is least responsive to dopaminergic drugs like levodopa and carbidopa combination that we normally use, as well as amantadine. So I was reading one of the neurology journals recently. There hasn't been much emphasis on the other motor symptoms, as is just of the trap symptoms that happens when the patient arrives. But these are the symptoms which we shouldn't ignore when the patient comes in, especially the hypomimia, the masked facial expression that the patient has. They have decreased spontaneous eye blink rate as well. And micrographia is one of the important presenting signs that we can elicit when the patient comes and we can ask the patient to draw something or write something. And they also have dysphagia, and they also are known to have some smell changes, as in have been described in most of the patients. Uh, there is stoop posture, as I mentioned, and camptocormia is severe anterior flexion of the thoracolumbar spine, which is commonly observed as when they follow their center of gravity ahead. These are the important non-motor symptoms as well. Was listening to podcast neurology one, which did mention that these are on the rise as well, and these are often neglected, as in the patients normally are depressed and they present with depression as one of their signs as well. So we should be looking up for these signs and symptoms as and when the patient presents. So there can be evidence of dementia and cognitive dysfunction as well, and these are per se one of the consequences of the Parkinson's disease per se as well, along with psychosis and hallucinations. So mood disorders, which are most common, are depression, anxiety, and apathy, and or abulia, which is decreased like motivation to do anything. So in terms of the sleep disturbances, Parkinson's disease is congruent with the sleep behavior disorders as well, which is almost a congruent finding. They almost always have that kind of presentation as well. They can also present with insomnia, daytime sleepiness with sleep attacks, along with restless leg syndrome and the REM sleep behavior disorders. So they can also present with fatigue or olfactory dysfunction. So it's basically a clinical diagnosis uh, based upon the history and the neurological examination that the patient comes in with, and we do it here in the hospital settings or in the office settings. So more often than not, it's considered bradykinesia plus either tremor or rigidity. Either of these, like one of bradykinesia and either of tremor or rigidity, is considered one of the diagnostic, like clinical findings, because postural instability develops very later on in the disease, as I mentioned earlier. So they must be present for us to diagnose the Parkinson's disease. So as I was following her, she was telling me that there's a recent this guideline that came up, more of a research as well as a clinical tool, the Movement Disorders Society Unified Parkinson's Disease Rating Scale. It's used for examination of cardinal manifestations. So it has four parts. First one being non-motor experience of daily living, and the second one including motor experiences, part three being motor examination, and part four being motor complications. So we have a questionnaire of about it has a rating of about 230 as the total number which the patient's um, total number can go up to as in this scale is concerned, as far as the scale is concerned. So based upon this scale, they have the threshold to consider to make the diagnosis of Parkinson's disease. Along with that, we can also use some ancillary tests, uh, especially to differentiate it from the other Parkinsonian syndromes, which can include MRI, ultrasound of the brain parenchyma, and DAT scan. DAT scan is commonly used as well. And recently, we found a skin biopsy. It was being started in 2020 in one of the case reports and in one of the research studies that they did first, and then afterwards they followed it up with some um, meta-analysis and some case reports, which did show that it has high sensitivity and specificity. So it's Parkinson's disease and along with uh, other Parkinsonian syndromes are part of the alpha synucleinopathies. So they are known to accumulate oligomers in the skin, so which we can use of we used it the other day as well here in the office where we had a punch biopsy of one of the patients coming in with either Lewy body dementia or dementia with Lewy bodies or Parkinson's disease per se. We were not able to exactly hone into what exactly is the diagnosis, but we did that punch biopsy here, and even the rep was telling us that it has high sensitivity and specificity to almost the extent of 90 to 95%. So it's one of the upcoming themes as well. It might be inculcated into the diagnostic algorithms anytime soon. So as far as the treatment is concerned, most of them must be aware of the treatment here. So it should be begun when the motor symptoms start to affect the quality of life. We normally start with Sinemet, which is one of the combination drugs of levodopa and carbidopa. We started with 25/100, and that to instant release tablet for the initial titration, and then we have to take it half tablet 2 to 3 times daily with meals. So we have to be cautious here. We should not be starting. She was telling me, the movement disorder specialist, she was telling me that we shouldn't be starting any patient with 10/100 of the dose of Sinemet, which in fact worsens the initial symptoms, and the patient can go into higher titration. He might need higher titration later on. So have to be cautious with starting with 2500, and it should not be stopped abruptly because the sudden withdrawal has been associated with syndromes like neuroleptic malignant syndromes or even akinetic crisis. So, so we have to slowly up titrate it as and when the patient starts to develop dyskinesia or off phenomena. More so often that happens with levodopa carbidopa combination. So in select cases, we do start the patients on dopamine agonists like pramipexole or ropinirole, or even the MAO inhibitors, the selagiline. These are mainly considered if the patient has very mild signs and symptoms, especially the MAO inhibitors, because they are considered once or twice a day. But for Sinemet, it has to be more of a compliance issue as well, because it has more frequent dosing. So we can go up to as high as she was telling me up to about 8 times daily of Sinemet in a day at this dose. So also apart from that, we can use amantadine, which is a reasonable alternative. So with especially with younger patients, as in when they have the higher risk of developing dyskinesia and later on in their life because they are younger than 40 years, that is when we consider dopamine agonists more so often. And the patients with mild symptoms, as I mentioned, has more preference for once a daily medication, in which we can consider MAO inhibitors. So in the patients under 50 who are at high risk of dyskinesia, and we start with monotherapy with pramipexole and ropinirole. And another medication another group class of medication which we can commonly use are the COMT inhibitors, which are entacapone, talcapone. So if the levodopa adjustments for wearing off are not adequate or adequately or adequate or tolerated, then we can add dopamine agonist, or we can think of adding a COMT inhibitor or MAO-B inhibitor per se if the wearing off phenomena is not getting controlled, even with the even with the slow release of the tablets, like Rytary, which we have been commonly using in the office as well. So I was reading through few journals which were saying that instant release tablets to start with, and then we can later on think of switching to slow release tablets like Rytary, which is also like an alternative of Cinemet per se. It's the same formulation as an of Cinemet, but it has a slow release phenomena in which it maintains the level of dopamine in the brain. But in the studies, it hasn't been shown to be as efficacious or even more efficacious, I would say, than Cinemet per se. So for the off phenomena, recently these subcutaneous apomorphine injections are also one of the options which are considered for sudden, unpredictable off periods. So apart from that, if these doesn't work and the patient is on maximal dosing of Cinemet along with other dopamine agonists or MAO-B inhibitors combined, and the patient is still having resting tremors, disabling his normal day-to-day functioning, then we can think of going towards the surgical therapies like deep brain stimulation. And also these are used for motor fluctuations and dyskinesia, which develops as a result of these medications, that is the Cinemet. So then we should refer the patient firstly to movement disorder specialist who can coordinate with the neurosurgeon to get these surgical therapies done like deep brain stimulation and continuous levodopa carbidopa intestinal gel infusion, in which they make a tract into the intestine directly by an ostomy bag, and then they infuse it directly. And also we can use continuous subcutaneous apomorphine infusion, which maintains the level of dopamine. Which is more so for the off phenomena, and the carbidopa levodopa combination, which is a continuous infusion, maintains the level of dopamine in the brain. So these are some of the surgical and device assisted therapies that we can use if the patient is not getting better with the medications per se. So that concludes my presentation here, and these are some of my references which I used to make these slides. And any questions you would like to ask, please go ahead. And I would like to thank once again Dr. Stein and Dr. Bernard and my colleagues here. Thank you.
Okay.